Today we really are trying to follow the story with the professionals. We have a couple of, I think, very distinguished guests who might be able to help us with some of the questions and maybe even get into a very specific area regarding the testing question as well. And, in fact, we start right out of the gate with Dr. William Morice, MD, PhD, not to mention president of Mayo Clinic Laboratories. Mayo Clinic Laboratories made a very big announcement yesterday, rather momentous one. And Dr. Morice is kind enough to join us right now on the Whiting Clinic LASIK and Cataract Hotline. Doctor, first of all, thanks for giving us a couple of minutes. We very much appreciate it.
Oh, Dan, it's my pleasure to be on and have a chance to talk with you about what's going on with this really rapidly escalating problem that's facing our country.
Let's start with the news that I think you guys broke yesterday, that you have developed a test that can detect the SARS-CoV-2 virus in clinical samples. That is the virus that causes COVID-19. Tell us a little bit about what leads up to that, how significant that is, and why it is significant.
So it's an interesting, at least interesting to me, kind of story in the way the events played out. We, of course, through Mayo Clinic Laboratories, I'm a pathologist at Mayo as well, and I've been down there for over 30 years, actually. But so we have a history of really looking out to what patients are going to need and trying to continually develop new tests to help patient care. In this case, we do have a history of looking out for pathogens that are emerging around the world and developing tests for them. Zika virus being the last one prior to this, that was really one that kind of hit the U.S. public. So our doctors really started worrying about our ability to provide the testing for our patients probably about a month ago. At the same time, we also have a joint venture partner lab in China with a company called Wuxi Diagnostics, and I talk with them weekly, and I really got to know firsthand how this virus was really overwhelming the Chinese healthcare system quite quickly. So I work with Dr. Binneker, the head of our virology lab, Dr. Patel, the head of our microbiology testing division, clinical microbiology, really made the decision that we wanted to proactively start developing a test for this, because really there's no specific treatment at this point. So most important is to identify early who is infected with the virus. So we really start working essentially around the clock to get something that would be available as soon as possible.
You had mentioned yesterday, doctor, that this test should help ease some of the burden currently being felt at the CDC, Centers for Disease Control and Prevention, state public health laboratories as well. When you say burden, are we talking about, again, I think one of the concerns I keep hearing about over and over from the medical professionals is a frustration with the lack of testing capability or enough testing capability. There's been stuff written and said about the CDC kit might have been a bit flawed and missing some things. Is that making this more challenging than it might otherwise have been, or was it always, were you always going to be needing other institutions like Mayo stepping up to sort of take the pressure off?
Yeah, it's an interesting question. I mean, honestly, the CDC, the system by which this typically happens is that as an infection becomes known, we first test through the CDC to make sure that the testing is accurate, and also to give the country a sense of how this disease might be entering or playing out as it comes within the continental United States and the United States. But in this instance, and then over time, hospitals and laboratories such as Mayo Clinic Labs, DLNP, Department of Laboratory Medicine, will also make a diagnostic test as the disease becomes more established. In this case, there really were a number of factors which overwhelmed that system, which usually works quite well. First of all, it started in China, and China, by law, does not allow specimens to leave the country. So the sorts of specimens that might be shared between countries or that might be sent to a place like Mayo Clinic, because we do get specimens from around the world, that would give us some material to work with and start to establish what this is. We didn't have that. Then once it came to the CDC and into the United States and the CDC testing process, the other challenge is that it's infectious early, when oftentimes patients aren't aware that they have the virus or they have very minimal symptoms. And so really there was sort of this, everything happened has escalated so quickly, it's really overtaken what is usually a pretty reliable system to help manage these things.
As I understand the way the protocol works, Doctor, data from this test then gets submitted to the FDA for review and emergency use authorization. Translate that to those of us who don't understand that language. I guess what I'm trying to lead to is in real time, how quickly can what you guys announced yesterday be helpful and useful in testing, having the capacity to test more people more quickly? Well,
I mean, clearly, it's useful now because as soon as we announce we have the test, that means it's available.
Right.
And it becomes then a matter of just getting enough equipment, because we do about 25 million tests a year in Rochester. Over half of those come actually from outside of Rochester and are sent again from all over the country. And so we have the facilities to really manage taking in the testing from anywhere.
Okay.
It's a matter of having enough material to actually run the test. I mean, that's really the next hurdle. And also, as you can imagine, there's different types of machines in the laboratory. Some of them are very highly automated that can do thousands of specimens, and that's really where we're working to try and make that happen. What you described, I mean, the FDA has a very important role in healthcare in making sure that when people make claims about anything, a drug, that it's safe and for its intended use. For some tests, they also like to see the same sorts of assurances given to the public before they're rolled out. As you can imagine, that involves a lot of paperwork, a lot of studies, and so typically to get something through an FDA process it's a matter of years or at least many, many months. In this case, really what's happened is we've now compressed our ability to work with the FDA, to work with industry, to try and do all this at scale much more quickly. Where we needed some latitude with regulators was that as clinicians in the lab, we do have the ability to develop tests and prove that they're useful and prove that they do what we say they're going to do without going through the FDA. And so that's really where we have been working with them to see, can we relax some of the criteria that they would use normally to prevent inaccurate tests,
right?
To make sure that we can get as much testing out there as possible. I can tell you that from talking to my colleagues in China, my understanding, I didn't see the data firsthand, but my understanding was that with the opposite approach, where lots of labs were allowed to introduce tests right away, there were some that didn't perform, and so that's the downside of doing it too quickly. And this can be a tricky problem because there are other coronaviruses that cause upper respiratory tract infections, and they're quite closely related, as you can imagine. So you really don't want to tell someone they have coronavirus 19 or the SARS-CoV-2 virus unless you're really sure that is in fact what they have.
Dr. Bill Morice, Mayo Clinic, president of Mayo Clinic Laboratories, with us here on The Fan. You mentioned your connection with Chinese medical officials. Have you been able to learn? I think, look, we're all, especially lay people, scrambling on this, trying to figure out what can be learned from where this thing ratcheted up early, and whether we can get any kind of hope out of where it might be now, or any kind of really important lessons can be learned if they were bad lessons for us to eliminate going through that same process. What have you, in the conversations you've had, anything that might be useful for our audience in terms of what you've learned?
Yeah, well, first of all, yes, is the short answer. I think a couple of things, in communication with WuXi, which is really a global company in and of itself, one of the things they took it upon themselves to do was to start to publish a lot of information early in China, because there was so much going out in social media and other channels that was incorrect. And so really having public awareness is really important. There's a lot of unknown here, which of course engenders a lot of fear and consternation. We are learning a lot more about the virus. The two things I think that are really important, different than the prior SARS virus, this is one, as I mentioned earlier, that it can be infectious much earlier. Mm-hmm. So identifying patients early is really important. And the other thing we know is that containment is also really important. And so I think we're learning things along the way here that will help us to really manage this It's just, but again, a lot of it is getting good information out to people so they really understand kind of what this is and what it isn't, as we, as a medical community, start to understand that ourselves.
Is it your understanding that the key to aspects to minimizing the situation in this country are as much testing as aggressively and early as possible, and then the social distancing? Or is it a little bit more complicated than that? Is that what it comes down to, or would you say there's more?
No, I think that's right. I think that with the testing, I think it's important because, again, this is just very unusual where you'd have essentially at the turn of a dime 200 million Americans worrying about whether they need to get a specific diagnostic test, which didn't exist 2 or 3 months ago. So I think really understanding that we make sure the patients that are at risk or they're exhibiting any symptoms get testing. So make sure that we test the right people so we don't overuse the resources that we have, just testing everybody. And then I do think the containment and the hand washing and the social distancing, those are all, honestly, that's why hand washing practices are still really important quality metrics in hospitals. That's a really important way to combat the spread of infection. So there is a little bit of sort of a common sense element to that. But I think it's really a combination of both. That's really most important. Again, because there's just not a lot you can do that's specific to the virus once the person is infected. It's very much supportive care, and it's really helping, like all viral upper respiratory tract infections, it's really making sure we protect people that might be particularly vulnerable to getting a viral pneumonia, which is really what gets patients in trouble with this virus, as it does with many others.
It's interesting in trying to read from authoritative places online. There isn't, I don't sense unanimity even among the medical professionals about where this is going to go or how bad it's going to get or how big it's going to get. And so I think for a lot of us too, again, it's made it difficult to know. The old deal of no one wants to overreact and get hysterical. In any case, I guess that's not very helpful, even if it's going to get really bad here. But regardless, we don't want to underreact. We don't want to overreact. But, there's some folks who've projected it's inevitable that tens of millions of Americans, if not more, are going to get this, that we're past the point where we can stop that. What we have to do is understand that doesn't mean everybody who has it is going to die, and that doesn't mean that we can't now try to, stem the tide somewhat. And then others haven't projected as much, and I'm trying to figure out if they're not projecting because they don't want to scare us with what they really feel is the truth, or because we still are not sure about some aspects of COVID-19.
I think it's probably two things. It's more the latter, and that there's still many elements about this that we don't truly understand. One thing we don't truly understand, even if you look at Washington, there's a notion that maybe the patients that were the index cases were actually, the infection had been there for some time, and we didn't even know it because we weren't testing for it. So there's that unknown. We are actually now working on a blood test. That will be the next phase of this, is to work on a blood test to be able to understand if someone had the infection recently, so we can understand more of the spread of this. I think there's that element of still not complete information on how this is spreading and what the real prevalence is in some of these areas. And the other is it's just like anything with a lot of this predicting what's going to happen, it's all around statistical modeling. And so just like people try and predict the markets and people try and do now, the baseball and all that stuff, it's all around statistical modeling. And so those models, as you know, in sports and everything else, the model that you use can pretty dramatically affect the conclusions that you will draw. And so I think that's a lot of what we're seeing here is different models of what might happen, but we won't really know. I think that people being aware early, getting the care they need early, taking care of themselves early in an infection, those sorts of things will probably have as much impact as anything else.
Two last things, and we appreciate the time of Dr. William Morice, President, Mayo Clinic Laboratories. Each day, as long as this story, or once this story is developed, I've received at least 5 to 10 emails from people who basically say this. They go, I get we got to be careful, we got to be vigilant, but it doesn't seem like that many people have it, and we know what the seasonal flu does every year, and what makes this different that makes us feel we need to go to the extraordinary, unprecedented, quite frankly, lengths we're going to try to, pause all of sports, pause all of popular culture if possible, where the people assemble, and shut down as much of our daily life as we possibly can. What would you say to those individuals who remain skeptical that we are taking steps that are over the line and actually needless?
Well, I would say, number one, I understand their skepticism and can appreciate it. I'm a big Minnesota sports fan, Wild fan, and so I'm as disappointed as anyone to see them stop 1 point short of the playoffs here. But I think you have to play out the converse. So if all of this comes to pass and this doesn't play out to worst-case scenario planning, many will probably pillory those who said to be cautious because of the measures that were taken and the disruption it caused. The flip side is if this really turned into the Spanish flu of 100 years ago, there would be a hue and cry as to why wasn't more done. You'll never know the true benefit of preventative measures because they, by nature, prevent what you're trying to avoid. And even from a sports perspective, I mean, if people went to a Wild game and a number of them end up succumbing to the illness or players succumb to the illness, I mean, the ramifications from a societal perspective would be even more pronounced and dramatic and long-lasting. So it's difficult. I think it would be easier if we knew more. But I think as in medicine, as in life, when you're really talking about protecting life and limb, you really have to take measures towards preventing the worst possible outcome.
So you would agree that the steps that are being taken are prudent and necessary, given what we still don't know and the concern about how much worse it might get if we do not try to implement as much, for example, social distancing as we possibly can in a free country.
Yeah, I think that the experience in northern Italy certainly would suggest that it is more prudent to be more to take a much more cautious approach in terms of limiting social mobility at this point in time. Again, I don't have first-hand experience there, but in reading in the medical literature, what has happened is that the number of patients that have developed the severe respiratory viral infection has actually overwhelmed their ability to care for those patients, such that it's actually overwhelmed the number of ICU beds that they even have in that region of Italy, which is then your face as a society is saying we have to decide which patients we think will get access to intensive care and intubation and supportive therapy and which ones won't. Those are much tougher questions even than the ones that we're asking ourselves now about limited access to resources and limitations on our social mobility.
Last question, I promise. We know that a vaccine is going to take a long time. Now, I don't know if they're, again, in unusual circumstances, able to ramp things up or cut a couple corners or gamble a little bit more. But the issue of antivirals to give to patients that might treat them and help them better cope with the virus if they get it, COVID-19, is that feasible? Is that what people are working on? And would that be on a different timetable?
Well, I think the direct antiviral therapies would be on a different timetable. Viruses by their nature are much more difficult to treat than bacteria because they live within our own cells, not like bacteria that live outside of our cells and their own organisms. The vaccine, I think there you have to really be careful that the cure is not worse than the illness. Again, the number of people that will actually develop severe complications from SARS-CoV-2 is still not entirely known, but it's certainly less probably than, it's somewhere less than 5% most likely. When you give a vaccine, we all know I've heard stories of vaccines that can themselves cause a number of, because they incite your own immune system, there are patients that get into problems with neurologic conditions like Guillain-Barré and other with vaccines. So I think that's why we need to be careful about what we do in response to this. There are some older, if you will, therapies such as protective anti-sera that have been used and have been shown to be a benefit in some cases in here in an experimental way. So there are other options, I think, for the academic medical community to consider potentially around the severely ill, which is really the ones that need the support, and really, again, my understanding is that once these patients need intensive care, it can be a very protracted period of time, up to 2 weeks. So if there's anything that can be done there, I think that's where probably where the therapeutic interventions and the experimentation will focus, again, because those are patients that are at high risk of fatality. So you want to take more heroic measures in that kind of scenario.
We really appreciate the time and for you getting back to us basically same day, basically almost as soon as we requested it. Much appreciated. Thank you once again for the time, Doctor.
Thanks, Dan. I really appreciate the opportunity.
Absolutely. Dr. William, he likes to go with Bill Morice. He's MD, PhD, immunology, the president of Mayo Clinic Laboratories, and they had announced yesterday, as we talked about on yesterday's show, a big breakthrough in developing a test to detect COVID-19 infection.